do. Good evening. I'd like to welcome I'd like to welcome everyone to the Spotlight Zoom recording for the Australian Federation of Medical Women. My name is Dr. Brenda Masters. I'm the president of the Australian Federation of Medical Women, and I have with me Dr. Jennifer Green, who's an orthopaedic surgeon in Canberra. Now, before we get on with the introductions, I really would like to start by acknowledging the people whose land we're meeting on. In our case, Jennifer is actually in Canberra with me at the moment, both in our own homes. We are working and living and recreating on the land of the Ngunnawal and the Ngambri people, people who have an immense connection with the land and who have a cultural background over the millennia. We are just small pimples on the landscape compared to the immense contribution they've made over the years. So I acknowledge those people. I also acknowledge the traditional custodians of the lands on from the people who our various viewers around Australia and potentially overseas are meeting. Tonight we have with us Dr. Jennifer Green. Jennifer Green is an orthopaedic surgeon specialising in hand and wrist surgery. She's been in Canberra since, I think, 2016. Is that correct, Jennifer?
Yes.
Yeah, and has really made her mark in the sphere of diversity in procedural medicine, especially in orthopaedics, but also in surgery. Diversity, initially it looked like inclusion from a gender perspective, but it's been broadened to general diversity from all groups of surgeons and clinicians who are underrepresented in standard medicine. It's a fabulous sphere to be engaged in, and I'm really excited to have this opportunity to speak to Jennifer about it. I'm actually just going to hand the floor to Jennifer because she's just got so much to say. Welcome, Jennifer.
Hey, thank you so much, Brenda, for having me. I wasn't quite sure of the format, so I'm going to talk a little bit and show a few slides about some of the work we've been doing in diversity, equity, and inclusion. Might start with that first. This is a presentation that I'm giving in about a week over in Washington, so that should be quite exciting given the current situation. Hoping not to be stampeded by protests. So now, is everyone able to see that, Brenda?
I can see the whole screen. Can we make it as a slideshow presentation so we don't have the side panel? Is that possible?
Yes, apologies for that. Absolutely. Let me just go to...
Just means it's bigger for us. And
yeah. I understand, easier to read. Yeah, let me go to... Oh, sorry, just... Okay, set up. My apologies.
Maybe play from the start.
There we are. No, I've got it.
You got it?
Yeah, let's just do that. There we go.
Yay.
So, excellent. So I thought I'd just talk briefly. I know a lot of people on board are well aware of what diversity is, but it really includes everyone. So diversity is not just gender, which, really that's a pretty important part given that we're more than 50% of the population as women, but it includes race, ethnicity, LGBTQI people of varying abilities. It's not, a lot of people have a perspective that this is just an ideological argument, but it's actually not. It's actually an evidence-based strategy where we can improve healthcare. If we look at some of the concepts around DEI, equality is considered, mostly where we are now, where everyone has the same opportunities, but we come from very different levels, whether that's your demographic background. You may not have the opportunity to have high-level education and get into medical school first time or get onto a training program. When we look at equity in the middle page there, middle of the section, it's trying to boost those opportunities to level the playing field. It is not giving people advantages, it's actually leveling up. And there's a lot of misconception that equity is just taking something away from someone who has an advantage and giving it to someone else. It's actually just elevating everyone to the same position. And inclusion is when we don't actually have any barriers anymore. And that's really the target. There is plenty of evidence showing that organisations who are more diverse, at least 30%, attract the top talent, are more innovative, and they make better decisions. So it's actually so much better to have a diverse organisation. But particularly if we look at medicine, and my field mostly has been the surgical and orthopaedic workforce, there is a lot of data now showing that we actually have persistent healthcare inequity if we don't have representation of minorities and women and LGBT members of the community in our surgical or medical workforce. So I consider diversity, equity, inclusion as a priority for healthcare equity, and that's what we're driving for. A lot of the barriers include unconscious or implicit bias, which are just the thoughts that people have that are influenced by lots of factors, such as your upbringing. They can be, to do with people's age or their religion or stereotyping people, and just being aware when you meet someone what your biases might be, just thinking about how you have immediately thought about this person is quite insightful. This image really made me realize the first time I saw it that, we all have unconscious biases. I was surprised to see all these women who are Malaysian orthopaedic surgeons. And it made me realize we all have different biases and we need to recognize them. This is one of my colleagues.
That picture has one person who has a very male phenotype. Third
Yes.
from right at the bottom. So is a female orthopaedic surgeon.
Yes, in Malaysia.
Wow.
Yes. So again, more on Malaysia later because it's very interesting. They actually have had more female leaders in their orthopaedic association than anywhere in the world. And one of the interesting facts that might contribute to this is that in the operating theatres in Malaysia, there are prayer rooms for men and prayer rooms for women. And the women surgeons and nurses have kitted out their prayer rooms as dual-purpose breastfeeding rooms. So they have created a safe space for women who are of childbearing age to work in operating theatres. And one can't not think that this is somehow related. So they have nearly twice the percentage of women in orthopaedic surgery in Malaysia as we do in Australia. So so I have learned many things and been constantly curious. You find out all sorts of interesting cultural differences, and we can all learn from each other about how to improve diversity and equity. And this is on the right here is one of my colleagues who, Linda Chikotho. She lives in the southeastern part of Africa, in Malawi, and she has a PhD and presented at an international meeting recently. And on the left are some of the orthopaedic graduates in Africa. So, we often think about places we don't know very well with a different perspective. So there are just a few examples here. You can have affinity bias where you feel a really strong connection to people who are similar to you. Then there's the perception bias where we tend to stereotype people. The halo effect is where we project positive qualities onto people when we don't actually know them, but we've been given a lot of information that makes us think they're good. And then confirmation bias is when you have a belief that someone is potentially inadequate, and then they do something that affirms your bias, even though that may not be representative of them as a whole person. If we look at this term intersectionality, that relates to having more than one of these diversity characteristics. So, for instance, if you are of a minority race and you're female, it will be harder for you than it is for someone who is a white male. So having the more of these diverse characteristics you have, often the greater the challenges. We know there is.
Can I just ask a question?
Don't hit me anytime.
Yeah, thank you. You mentioned white male. That's in our society. I'm sort of harking back to that fabulous photograph of the female orthopaedic surgeons in Malaysia. If you were a white male, like Anglo orthopaedic surgeon in Malaysia, would they experience the same sort of biases and disadvantage as one of these surgeons would in Australia?
I suspect not, because there are a lot of cultural issues with invited guest speakers coming from white Anglo-Saxon male nations to Malaysia and other nations. So, there is, I couldn't comment completely on that subject, but I think the white male might feel uncomfortable being in a group of people who do not look like them. However, there is still a bit of a power imbalance on a global, an international relations level between, a male, for instance, from America coming to Malaysia. And that doesn't go across the board. Of course, there are some amazing male allies in all nations. But yes, it's different for every culture, I think. And there's nuance throughout every culture and every individual. So there are a lot of social determinants of health. We know that people who have poor quality, poor access, or poor education, or poor economic stability are much more at risk of poor outcomes. One of the studies that most impacted me when I was looking into healthcare inequities was this study, obviously not from orthopaedic literature, but they looked at 1.8 million births in Florida between 1992 and 2015 and found that Black babies were more than twice as likely to die in their first year, regardless of the mother's income or education. But when Black doctors cared for Black babies, the mortality decreased 50%. And so I would challenge people who think that there is not a problem in the lack of diversity in healthcare. And we have a lot of studies in orthopaedics as well. We know that one study from Canada several years ago showed a male patient with the same degree of osteoarthritis of the knee was 22 times more likely to be offered a knee replacement. 22. That is not a misprint. And another from the New England Journal of Medicine, very important peer review journal, that although the underuse of arthroplasty was poor for both sexes, the degree of underuse was 3 times as great in women as men. And no doubt some of this is because women do not present, but some of it is also because they're not offered treatment. Now, if we look at racial inequity, there are high rates of lower limb amputation if you're non-white in the US. Most of this data comes out of the US. Poor access to knee arthroplasty and poor outcomes, with African American athletes, of which there are many high-ranking athletes, they have significantly delayed referral for ACL reconstruction, and children of parents who have English as a second language have delayed access to orthopaedic care. But apart from all the bad news, there are some studies that have analysed healthcare outcomes and found that if you actually have diverse healthcare teams, you have not only better healthcare outcomes, but you actually have better financial outcomes as well. And we know there's not a problem with female surgeons. There's plenty of evidence. You know, I don't really like to pull this out too much to offend people, but in this gathering, we know that the patients of female internists die less frequently. Patients of female surgeons have fewer complications. And there's even a study now of the male and female surgeons doing hip replacement with the outcomes being the same for both. In orthopaedics, we are very underrepresented if we look at women around the world. In fact, Australia is way down in the middle here. We have crept up to 6% women now, and we've been working towards higher rates, and we are very pleased this year. 30% of successful applicants to training were women. So things are moving forward with strategy. And if you look at, you know, Germany, Estonia, Spain, Denmark, you know, we assume Denmark and Sweden and Norway are going to be quite high up, but they're still not even up to the 30% where diversity actually starts to have an impact. So quite a long way to go. And this is a map of that previous data. So you can see Australia's not really ticking a lot of goals here. We're kind of paralleling lots of nations that we, you know, would hope to aspire to, as a supposedly progressive nation, to do a bit better. This woman is the first ever president of an orthopaedic association, and she's still alive, very involved still in her early 80s, no longer practicing. But she was a leader in 1986, way before we had our first in Australia in 2021. And there has only been one leader in the American Academy and one in the Canadian. So, you know, all these yellow marking people, they are all from the Asia Pacific, and you can see the blue are mostly European. Yeah. So between the Asia Pacific and Europe, there have been quite a lot more female leaders in a very male-dominated specialty, and it'd be interesting to see if this includes other specialties in medicine as well. You know, we really need to not be cookie cutting when we're selecting people, and sadly, those initiatives are all being thrown out the door in the US. And I do fear that we may end up having a similar situation where all the DEI initiatives are wiped away, or the funding is removed if you choose to protest against those powers that be. But essentially, there is no longer funding for medical schools that promote DEI. They are trying to use different methods to identify those students applying who probably come from groups that are underrepresented, but it's become a lot more problematic and has had to really go under the radar. This is what it looks like for the trajectory of women in orthopaedics in the US. They've got a couple % more than we have, around 8% now, 7 maybe, 7 to 8. So we're looking at taking up until somewhere around 300 years to reach parity. So you know, if you do nothing, things certainly don't go ahead very quickly, and they often go backwards. And some of the, yeah, it's crazy. And you know, when men in my sphere, particularly the younger men, ask, why do we need diversity? Aren't we doing okay? And I say to them, you know, it is 300 years to reach gender equity okay? And that the data is a bit shocking. Sorry, I'll just go back. And some of this we're teaching to our students through our curriculum, and it's not always the specialists who are telling people not to go into orthopaedics if they don't fit that stereotype. It's a lot of these barriers that are created through the hidden curriculum, which is the lower part of the iceberg, and they're the things that are implied or communicated by behaviours and commentary when you're at medical school, like, you know, you're not really welcome in surgery if you're from any of these groups, or it's a boys' club, or there are still so many women in medical school who think you can't have children and be a surgeon. It is surprising. So, you know, the way to improve it is, you know, visible role models, which I know is a lot of what the Australian Federation of Medical Women is doing. And part of the problem is we have so many women in medicine now graduating out of medical school, but still this little trickle into certain areas. So there are a number of really useful initiatives if you are trying to attract women or other underrepresented groups to come and work with you. And one is providing some good visible role models. Two is trying to understand where the unconscious bias is and mitigating that unconscious bias, whether it's in reporting, promotion, selection. We have quite a rigorous selection program in orthopaedics that's very open, and it assesses people on many different levels, including their communication skills and interviews, as well as their knowledge. And though continually reviewing what you're actually achieving is all part of it. Understanding where you've built in accidental biases. Things like when I was on the board, there were positions coming up and people would just say, oh, who should we choose for that? Who should we tap on the shoulder? And I said, well, we're going to decide in this room for an organisation of 1,300 people. How about we be transparent and advertise? And that has really changed the way the representation of women and minorities in orthopaedics. So having those leadership opportunities is so important because it creates the role models as well, and flexibility in training. I think everyone is trying to do that now as best as we can, and providing mentorship. We've been doing a lot of mentorship and also having workshops to bring young women who are interested in to have a look at orthopaedics and talk to orthopaedic surgeons, men and women.
Can I just ask, you mentioned, I think, that around 30% of the intake of trainees is now women.
This year was women, highest ever.
A massive improvement. But do you think that the women who are in the training program have their own biases, and that they've selected themselves as women who are going to, you know, push career and choose not to have the family, or not to have you know, other you know, caring roles? Or is it, are you able to comment on the women?
The common denominator that one study showed a while ago was having a lot of grit.
Grit, yeah.
grit.
So it's a personality trait.
I think it's a personality trait, and the opportunity to actually touch base with surgeons, with orthopedic people, and be encouraged. You know, they talk about these moments of mentorship where someone reaches out to you when you're in the operating theatre or whether you're in the emergency department and takes the time to explain something to you and take you under their wing and teach you. Those moments can be really powerful. A lot of women in orthopaedics could tell you what actually affected them. For
Is
me,
that what happened to you?
Yes, not by an orthopaedic woman, but by several surgical women. So I've had a wonderful general surgical registrar when I was training in Sydney before I started doing orthopaedic training, and she really took me under her wing and showed me that, you know, it's just the same as everyone else. You know, you don't have to be male just because all the surgeons are. And I think just having those people standing up, those role models, just opens a door. I came across a couple of women training in orthopedics, in general surgery, one in plastic surgery, and later on a couple of the fellows who came from overseas to do orthopedic or hand surgery. And I think just having those women around me had a really, really positive effect. I see people who, you know, I was with when they were juniors a long time ago who have come into surgery or into medicine, and most of them, they remember their role models. You know, it's that personal interaction, I think, and showing that you care about the person and showing them how interesting something might be. How about yourself?
Yeah. How about myself? I certainly got a lot of encouragement as a junior doctor from mostly male proceduralists who could see my interest and who could see my, abilities. But in the end, I chose a non-procedural pathway, partly because of a few life choices I made.
Yes.
Marrying someone in the military. Now I know you're married to someone in the military, and I couldn't see a way to become a specialist, to become a proceduralist while following, being the army wife, and yet you've managed to achieve.
Well, you know why, Brenda? Because I didn't meet until after I finished my training.
Well, there we go.
Once I was in practice, I had a lot more control running my own practice as well as working in the hospital, and I could look after things a bit more easily. But having said that, I think I probably moved. This is my third practice through my career. So, people come to me now and say, can you help me out with moving practice interstate? Because I hear you're a bit of an expert.
Very unusual, because mostly you rely on a referral base, and to just pick up and move to an entirely new city is it's an unusual thing for a specialist to do, especially if you're not aligned to one of the public hospitals. So
yes, yeah, can be quite challenging, but at the same time, that's something to enjoy about a new challenge.
An area of expertise, and maybe it's given you a little more time to then further your interests in this gender diversity.
It has. I mean, if I was a busy on-call surgeon, I would not have time to do the other things that I've done. So, there are positives in everything.
Yeah, and let's find them. So I'll let you carry on with your presentation. Visible role models, hugely important, yes.
Okay, so, lots of visible role models. This woman down on the left here is my friend Dalal Bamshai. She is Saudi Arabian. And to the right of her, these young women, some of them in headwear, or all of them, are some of her proteges. And another surprising thing I learned in the last couple of years was that In Saudi Arabia, they have the same percentage of women in orthopaedic training as they do in the USA. So again, it's that unconscious bias. We think we know how the world works, but there is a lot of nuance out there. In the photo with the 3 women on the top row, this you will recall is one of the previous presidents.
Yes.
Yes, so Sarah and I were recently over in Samoa teaching orthopaedic trainees, and these are 2 of the 12 Pacific Islands orthopaedic trainees at the moment. So, there are women everywhere. They're doing pretty well, 2 out of 12. But there are initiatives going on all around the world to try and engage people into orthopaedics, whether it's Pride Ortho, who are trying to engage with their LGBT juniors. They're based in the US, but they also encourage other nationalities to join. In Australia, we have workshops. The bottom right-hand photo is a workshop held in Sydney a couple of years ago. So all around the globe, people are trying to engage. Oh, and I should say this middle photo here of the young lad doing the fixation is at the Australian Indigenous Doctors Association. So the Orthopaedic Association had been engaging with AIDA for the last few years and running workshops with the Indigenous students. And we actually have several Indigenous doctors in orthopaedics, better represented than the women, percentage-wise. So, some of the ways we can mitigate these unconscious bias issues can include having more diversity when you're selecting people, and that's one thing we've been doing. It just allows more ideas and more acknowledgement of our different opinions, and tend to get more people in who are more diverse. So you want a panel that reflects the diversity. As I mentioned before about the shoulder tap appointments from boards, we don't do that anymore, and that shouldn't really happen ever. But the problem being that if you have all these decisions being made in social settings where women, minorities, and LGBT people aren't there, then you do not get as much leadership from those groups. Having policies, having strategies, having policies that include various people on the podium when you have meetings, so there's more diversity at your meetings. And
so is there a lot of resistance at that high level in the colleges and the international associations to that concept of having the inclusive diversity at the
no
offices?
I would say that not in many. So in the Australian, Canadian, American, all the English-speaking societies, the leadership is incredibly on board with supporting diversity. And that has sort of happened only over the last sort of 7 or 8 years. It's been just slowly building. But in some nations, it's not something that is really spoken about a lot. And in some places, it's more a ground up movement of gradually trying to mentor people who are maybe not represented well. And then there are some nations where there's still a lot of resistance. But I'm speaking in May in Japan. The Japanese Orthopaedic Association has decided that they want to support diversity initiatives, and they have now a committee of women involved in this, meeting with the leadership and guiding them. So it is slowly happening in most places. Yes, there are still many individuals who are not on board, but as long as the leadership is on board, things do tend to improve.
Yeah, so even though the sort of the common membership is perhaps not on board, they're not protesting to the point where they're making it difficult for the leadership to take these initiatives.
No, there are usually, I think most of them realise it's not very politically correct
Yeah.
to be saying those things, but they do occasionally send slightly inappropriate emails and commentary suggesting that, women maybe, we need to be merit-based. As if we're
No.
selecting people who are not as strong candidates, which is really not an accurate representation. They can't really argue too much in that over the last few years since our strategy came in this country, we almost always have made appointments that coincide with a percentage of men and women that applied. And so the numbers applying are slowly increasing. And that's really now a lot of the people who started in our first workshop initiatives have come through medical school and been in medicine for a few years and are now entering into orthopaedics. So it's quite gratifying to see.
Is that a conscious decision to appoint trainees at the same percentage as applicants, or is that just the way it's worked out? I mean, have you thought, well, this is a fair way of doing it, or
I think
do you go in with a quota?
It has been, there's been they have really tried to select the right candidates, but let's say they're making sure there can be no arguments.
Yeah. So merit's 100% there, and
yes, I mean, most of our candidates are so dedicated, and it's really very hard to choose between them. However, if there is a position left and the next two people are male and female and they have equal scores, the policy has been to put the female or the rural person or the Indigenous person onto the scheme.
Right. So you've got it almost biased towards the diversity when all else is equal.
When all else is equal, yes.
That's good to
hear.
So,
there is a bit of pushback about that, of course, but it is what it is. We need more rural surgeons. We should have more Indigenous surgeons, and the evidence is out there to suggest we should have more female surgeons too. It's all about, as one of my colleagues from the College of Surgeons says, we are here to provide a healthcare service. And until our surgical workforce reflects the people we are looking after, there are going to be ongoing issues with the provision of healthcare to those communities that aren't represented. And even the Australian Medical Council is pushing this. All the colleges and the societies know that it is no longer acceptable to have a very, very non-diverse group as your society. So there is onus from the Australian Medical Council, as well as, fortunately orthopaedics have taken and run with it, and the College of Surgeons are very supportive as well. They're just think it's been a little bit harder in terms of the College of Surgeons is such an enormous group to actually manage that messaging and that strategy through several thousands of surgeons.
Yeah. I'm assuming the College of Surgeons has a few advocates such as yourself in positions to try to further that concept.
Oh, absolutely. There are many, many women on the College of Surgeons Council, and they include the president. The last two presidents have also been female. Karen Fielding, who's out at Wagga, she's the current president of the College of Surgeons. and has really been flying the flag for rural surgeons as well, to try and encourage better pathways for rural surgeons. We've also developed a pathway in orthopaedics for rural surgeons, so you can now spend most of your training in a group of far north Queensland hospitals working in a rural service and taking some time to the major city if you have a particular specialty interest. Because a lot of people are requesting a rural-based training.
And the beauty of that, of course, is that, you know, the time when you're training is the time when you're actually developing yourself as a person, as a citizen. You're partnering, you're starting your family, you're settling in somewhere. And if all of that time's been in a major metropolitan area, it's really hard to make the jump to something different. So I love that they're making it possible to do the training in rural areas.
Yes, and not all, but quite a percentage of Indigenous doctors are very keen to stay in rural areas as well. So, you know, it's sort of a dual initiative, both to provide that opportunity for everyone, but also particularly for Indigenous doctors.
Okay, what have we got here?
Oh, here we have one of my favourite tables. This shows 10 years worth of exam results for the American Surgical Board exams for those people qualifying as surgeons. And it compares those people who are unmarried with no children in the blue, compare men on the left, women on the right, partnered people in the orange. Silver is when you have married and have children, and and the yellow is just the average on all. So what do you notice about the
highest line is the unmarried women
on the right?
Yeah.
Yes. And I don't think that will surprise
not at all
any of our viewers. But, you know, this is why we need more flexibility. Look at how terribly the poor women with married with children are only passing at a rate of just over 50%. And it doesn't take most women much imagination to work out why that is. And that's why we need flexibility in training.
And interestingly, the men who are married with children are pretty much the same as if they hadn't been married with children, but
they're actually better off.
Marginally better off, but, you know, statistically not a significant difference. But, yeah.
No, but, yes, we all know it's great. Marriage is great for the bloke.
Yeah.
So, you know, some of the ways we could get around this are trying to make a competency-based training program rather than time-based. So if you need to take time out, you have achieved X number of competencies, you take your time out for whatever reason, and that might be you want to do a PhD, or you might want to go work in the military for a year or two, or you might have a family member who's very unwell, or you might be unwell yourself. It's not only for parents. And in fact, the first people to take this opportunity in orthopaedics were men who wanted to do other things and take time out for various reasons. On the right here, these are a few of my Queensland female colleagues and their families, just to show that, you know, women can have children, be orthopaedic surgeons. And the next thing is that mentorship piece. So, you know, mentoring people is so powerful, whether it's for a short period or a longer period. And sponsorship is a different concept. So sponsorship is when people talk about you in places that you're not present, and promote you for different leadership roles or opportunities in your absence.
Yeah.
And I think it helps a lot to have sponsors who are male allies to think about the women in their community who might be suitable for the role, who may not have a really high visibility. So, you know, having sponsors, whether female or male, is very valuable. But then on the flip side, there's that there are very few women and we get asked to do a lot because there aren't many of us. And at one stage, the 5% female orthopaedic surgeons in Australia were holding 17% of the committee roles, which, you know, can lead to burnout very quickly. So just, you know, there's a balance between being visible and self-care.
Yeah. Understood.
Yes, but I would say most importantly is having a leadership that is on board, because this study is an Australian study with Bain and Co and the chief executive women. And they showed that leadership was the driver for the most effective gender diversity initiatives, because they do the communicating and embedding the values. They ensure the recruitment and promotion are fair. They create the working models that support men and women with family responsibilities. And if they're visible and committed on these tasks, which fortunately, you know, RACS, the College of Surgeons and the AOA have been very visible about this and having a lot of promotion of women and diversity. We also have a committee that deals with cultural diversity, because we have a lot of diversity in orthopaedics in terms of ethnicity, but we have only had one non-white leader in more than 85 years of our society. Right. So trying to give leadership opportunities and sponsor those people that don't look like us is really, really important. This is really just to say you can't put one woman in a room and make them do all the work of diversity, and that unfortunately does happen a bit.
Sounds to me like it might have happened to you a little bit too.
Never. Yes, a little bit. Well, I have some great colleagues that we usually debrief on these things together, because I'm not alone. There are some amazing women doing amazing things. So really everyone benefits from diversity in healthcare. There is nothing not to like about it. You're attracting the top talent. You're not just choosing from a little cookie cutter pool of people. You get increased innovation from those diverse perspectives, and you make better decisions. And this is the pathway. All the evidence, we've got over 100 papers in the orthopaedic literature about diversity and leadership and initiatives that have occurred, and they all point to these main diversity strategies. So, you know, we can get there. And this is just a little plug for my passion project, which is the International Orthopaedic Diversity Alliance. And we now have about almost 1,800 members around the globe. And that's been a really fantastic learning experience for everyone, but also providing lots of networks for people that don't have networks, and allowing people opportunities for leadership and fellowships and training where they may not have been able to connect with those people.
So when do you think we will have 30% proceduralists in Australia across the board?
Look, it really requires a bit of cultural change from the organisations. So there are some organisations that are much more proactive than others and a lot more inclusive than others. And I think, you know, if orthopaedics can do it, there's no reason that other groups cannot achieve the same. I think the data is a little bit concerning if you look at the projections, but those projections assume we keep doing the same thing, and we're not.
Yeah.
We're trying to build strategy, and it's all about being strategic, knowing how to get there, and then setting the goals and looking at how your organisation can do things. And one thing I found really fascinating when I was on the orthopaedic board was just looking at decisions that were being made that would affect women, but because there were no women in the room except me, no one really thought about it. So it just showed me that if you don't have a room full of diverse people, you're only really thinking about certain perspectives, and you're missing opportunities.
You're catering to the common thoughts and the No,
yes,
totally understood.
So it's I think meeting other people who don't look like you and learning from them is really so valuable, and we can all learn from everyone. And I just try every day to be open-minded about people, or recognize if I am automatically stereotyping and sticking that behind me, because we all do it. We all do it. But just treating everyone the same way, being respectful, being kind.
Yeah.
Yes.
Yeah. Actually, I'm just a little interested. Do you think that referral patterns to female proceduralists, especially female orthopaedic surgeons, are different compared to others?
There is data showing that orthopaedic women spend a lot more time with their patients, and we get more complicated patients who need to be spoken to.
Yes, I was thinking along those lines.
Therefore, we earn less.
Yeah.
Because we take more time and invest more in each patient. So it's a double-edged sword, isn't it?
Yeah, well, you're working better, you're doing the right thing, but yes, you earn less because of it. And of course, that's exactly what happens in general practice as well.
It is. Women spend more time with their patients, no matter what field you're in. So
there we go. I think it's not a bad thing.
There we go. It's a good thing. It should be, it should be continued. And I just really don't think there's a good. I mean, the other thing is we operate a bit more slowly,
which is why you have fewer complications.
Which is why we have probably no one has directly linked that, but one might think it probably comes into it because it's not a race.
Yeah.
How fast you can do your joint replacement doesn't, within reason, if it's not crazily slow and patients having a terribly long anaesthetic, but being safe and making measured decisions is not a bad thing.
Yeah.
But I would like to say in finishing that I have lots of very amazing male colleagues who are brilliant and are also very supportive of having a more diverse workforce.
Jennifer, I have to say it's been an absolute pleasure hearing your passion and understanding the impact that you personally are having on this aspect. I must admit, I had no idea that you were putting so much energy into this aspect of training and workforce until we started communicating around this interview.
Sorry to bombard you.
And I've known you for some time, so I just say, I applaud your efforts, and I do wish you all the best with this presentation that you're taking to the United States.
Thank you.
I do fear that things are not going to go so smoothly over there, but all the same, we have to deal with the situation.
Keep on flying the flag.
Indeed. So I look forward to ongoing interactions with you over the coming years. I thank you so much for taking the time to spend with us, and I'm hoping that a number of our members are going to take the opportunity to view this interview over time. I'll just pause the recording at this point, and we can continue the conversation afterwards.